And no, there seemed to be like this curly brown, medium-sized dogs.
Okay. So we're talking
And I'm a
about
dog
the
lover.
neighbor.
Really. I'm a dog lover.
Oh, you are?
Yeah, not that one.
Okay. We're talking about the potential for this podcast to be interrupted by a barking dog upstairs. So let's see what goes on. So welcome to Researching Happy. My name is Dr. Matthew Iasiello. I'm a little bit rusty. I'm just going to declare it now because it's been a very busy time. As you've heard me give a bit of a background in last episode, but very pleased to be back in 2026 with two guests. And there was a bit of a sliding doors moment where we were all in Australia for about, I don't know, a couple of months. And I only realized that like a day before Anna went back to Europe, I think. So welcome, Anna and Kiira. Would you like to quickly introduce yourselves?
Yeah, sure. I can go first. So, hi everyone. My name is Kiira Sarasjärvi, and I'm a PhD researcher. I just submitted my PhD on mental health field and well-being.
So my name is Anna and I'm Blasco. I'm from Spain. I'm an assistant professor of social psychology in the University of Lleida.
All right, amazing. So let's just get a figure on where everyone is, because you were in Melbourne, as we'll cover off, Anna, for a while there. You're back in Spain?
Yeah, indeed. I'm back to Spain. And I went to Melbourne. When was that time? I think that was in August, mid-August, up to the end of November. As you said, we just realized that we were exchanging almost the same schedule in Australia, just like 1 week before I came here. So pleased to have this conversation, to be the first conversation of 2026.
Awesome. And Kiira, so you've just submitted your PhD. Congratulations, first of all.
Thank you.
Are you still in Melbourne?
Yes, I'm still in Melbourne. So the PhD was done in University of Helsinki in Finland, where I'm originally from. But for the last 6 years now, I think it's my 6th year, I've been living in Australia. I was first 4 years in Perth and then recently moved back to Melbourne, where I started my first sort of unofficial postdoc at Origin under Melbourne University. Was it mid-year last year? So it's been a bit over 6 months. So it was also like when Anna came to research visit, it was like I just also started my position. So it was a really nice timing for both of us as well.
Yeah, awesome. So, I just on that, I guess, how did you both meet? Because I think Kiira, we met at a conference. Anna, I'd seen your work before, and then I saw, I think just before we met, Kiira, that you'd published this brief communication, I guess, together on the idea of mental wellbeing promotion in psychiatry. So how did you connect? There's lots of travel here. I often joke on the show that I live 2 doors down the road from my parents' house. So I have not moved very far in my life, although I've traveled. It's like a everybody loves Raymond thing going on in my life, but we're happy. You even did, I think you're the first distance PhD that we've heard of, Kiira, on this show. So anyway, how did you both meet? You ended up in Melbourne somehow together.
Yeah, kind of. I mean, we first met online. So we were both at Origin, which is a center known worldwide for the work in early psychosis, early intervention. And by the time I stepped in, I think that was what you were in a leave, you were on vacations, I don't know, or something like that. And I started working with Barnaby's Nelson's team. And I made my mind very clear, like, hey, I'm a girl of the wellbeing side. I'm interested in the clinical setting. I'm not an expert in psychosis at all. And then in our first conversation with Nelson, he said, oh, we have another of yours, another girl who's doing her PhD and she works on wellbeing too. So we waited until Kiira came back. So we had an online chat, and I think that was the moment where everything started. I would say that what brought us together was like being the quickie ones working in wellbeing in a center that was leading work on psychosis. I would say so, yeah. I don't know what you think.
Yeah, no, absolutely. I think it was like the stars were aligning because, I just started my postdoc position, and I was still trying to get a head around all the projects that are going at Origin. And Barnaby Nelson's team is doing a lot of world-leading research on ultra high risk in psychosis and young people. And I was like trying to okay, how do I fit in? I have a bit of background in my undergraduate in cognitive neuroscience, and I used to work in psych wards during my undergrad. So I have been living in the clinical world a bit, but then for my PhD, I jumped into population health and mental well-being, and the scale validation, very different. And I was like, okay, how on earth I will bring these together? And I feel like it was really nice support when Anna joined. And it was like a good way to, we definitely had a shared interest, but I also think maybe a bit shared frustration in terms of there was all these data sets and we are but nothing is actually capturing well-being. So there was a lot of questions we wanted to ask related to psychosis and psychiatry, but we did not have that many options or tools what we could go forward with it. So I think that was a sort of shared interest and frustration that brought us together.
Yeah. And we also had a number of interests in common too. So with the first catch-up coffee that we had, it was like, oh God, okay, I found just one of mine, it's like for me, Kiira was a huge support while I was at Origin. And yeah, it was a time that we shared a lot of thoughts on how we could do our work, how we could make the field progress, because we were involved, or at least some I stayed at Origin. It was an international research stay, because I wanted to see how they were running this huge project that they're doing in collaboration with a lot of other countries, which is depression. It is one of the biggest, if not the biggest, projects currently going on in terms of mental health. And I was very interested to know how this could be run and all the different data that they have, because it's a huge project. And then that's when we stepped in and we saw, okay, that's very few things asking about how people are doing well compared to how many measures do we have about are they reducing their symptoms? Are we seeing any progress in terms of you're less sick? So yeah, a lot of conversations were revolving around this question.
Yeah. I think shared frustrations should probably be the subtitle of this whole podcast series. That's basically what it's been, is just me complaining about things with people that agree with my complaints. But I was really interested to find you both, because I don't know much about Origin. I don't think I know anyone that works there. And not that means anything, but just for the point that, we do look from the outside in and think well, what do they think of well-being? Because I understand that obviously, and it's a big theme of the show so far, criticisms of positive psychology really not being taken seriously by other areas of psychology. And I think sometimes for good reasons, sometimes for not so many. And so I was just keen to hear sort of broadly, how do you think this idea of trying to advocate for well-being in a psychosis research world has sort of gone so far?
That's an interesting question. I think, well, I also shared some frustration in positive psychology as well, because I sometimes often feel like we are not really clear of the terminology we are using. Sometimes I do feel like it's made for people who want to better themselves, whereas my viewpoint is more okay, how do I help people feeling less ill and feeling better when facing illnesses? But I actually have had a really nice conversations with the senior staff at Origin as well. I think we might not use the same terminology, but the interests are there. So there's a couple of projects related to co-designing or trying to understand. And there's a lot of, we have a different setup for involving young people with lived experience who are trying to also help us to figure it out where to go next and what we should be researching. And you're seeing those projects popping here and there. But I think it's also lack of understanding health literacy. Even just me, have just finished my PhD on mental well-being, and I still sort of sometimes struggle with the term. And if I still think about mental health, the first thing comes to mind is still depression and anxiety. So it's so embedded in our brain to think the illness. And then it sort of needs to be forced thinking, okay, what's outside beyond that? That's like sort of my take.
Yeah.
I think that sometimes we have to even to grasp deeper. I don't know, my thoughts are that we know the knowledge is there. So these claims about how to understand mental health from a holistic approach are there. And they have been there for a while, so they're not new. However, I think that the translation in terms of the how do we do that in our work, I think that is one of the main gaps. I don't know. So I don't know what to think about that, guys, but maybe we have to retrieve back to more fundamental conceptual rules. Like, what do we understand about health? Not just mental health, but health. And I think that especially Western countries, we come from this dual perspective that comes from this time of this Cartesian separation between body and mind. So I think that this duality has quietly driven the following work on how do we understand and how to intervene on mental health. So either you have health or not, either you have illness or not, which are commonly treated as the same thing. And this has shaped, I think, what we understand as health and as recovery. So sometimes there is a lack of conversations between the different domains in psychology, not only psychosis, not only clinical settings, also from social entities, education institutions. So I think that my view is an optimistic one, but I think that we have to engage in common interest because we're talking about the same thing.
Yeah.
However, maybe centers like Ojan are more focused and they're super well equipped to work on and to address the illness aspect. And we need that these leading centers, leading researchers start like removing this separation because we need both forces. We need both of that.
Mm-hmm. Absolutely. I think oh, look, I just agree with everything you're saying. And I think in particular, we've tried, I don't know if you ever saw it. We wrote like a, what's it called? Like a commentary article of someone who was talking about the bipolar model of mental well-being, where like mental well-being and mental illness are opposites. We wrote a commentary and then they wrote a commentary back. And like, that's just not really very productive in a sense. Like, and I probably, at the time, like, you know, I was like pretty motivated to write some of that stuff. But looking back, I think now I feel it was probably the worst way really to communicate a disagreement because it just looks like and feels like an attack both ways. And so we're actually working together now on a bit of a paper. And I think what's coming out is exactly what you said, Anna, is that we actually agree. We just were looking at a different perspective. And I think for my part, I can put my hand up and say, like, I was probably like say comparing the bipolar model versus the dual continuum model. I was being very strict in my interpretation of a bipolar model, like it can't break this rule, this rule, this rule. But then of the dual continuum model, I was much more flexible, you know? And so like I was kind of like, yeah, like it works mostly, you know, but where it doesn't work, like there are reasons why and stuff. So, but really there's a middle position, which is that we actually do mostly agree. And that's what this paper hopefully will do, is get to the bottom of where do we agree, where do we probably not. And I think we might disagree on like maybe 1%. I think by the end of it, we'll probably actually agree. And so I'm with you. Like we are just looking at things in different ways. And I think that's even more embedded when you look like across disciplines, because these like ways of thinking about things are just more and more ingrained.
At what stage are you in this paper?
Good question. I would like to say halfway, but probably still very early.
Oh, cool.
Yeah.
Okay.
Yeah. There's a few. Yeah. Anyway, it's it's the idea was that it could be like we could do it over sort of Zoom and like talk, but there was like 3 different time zones. I know we're doing 2 time zones now, technically 3, I guess, because Melbourne and Adelaide's different, but across, you just can't, like, I would have had to wake up at like 2 a.m. and someone else has to wake up at like some other crazy time. So hopefully that progresses. But anyway, so do you think though then, like within Origin, like I don't think it's the case, and we don't have to talk about Origin specifically, but in that field, I don't think it's the case that they just go like well-being is completely irrelevant. It's just not on their radar sort of thing.
Yeah, I agree. I don't think it's like necessarily over like saying like this doesn't exist or like it's wrong. It's more like, maybe focus is being more symptom reduction and trying to get clinical trials that are focused on the symptom reduction. But yeah, like I said, I've seen a couple of new ideas and ways to like actually trying to think a bit more holistically. And thinking as well, like what is actually the goal of what we do? Is that like sometimes, and I'm pro medication, but pro symptom free, because we are treating serious mental illness, but it only gets you like certain point when the current science just doesn't improve it. And then I think there could be then consider, okay, what else? And like, I think one area of healthcare does it very beautifully is palliative care, whereas, we help aid with the symptoms, mention symptoms, but we also focus on well-being and the quality of life. It's just really shame it's only the portion that like who are receiving palliative care rather than everyone who could get treated for mental health challenges in the same way.
Yeah. We also have a paper coming out, hopefully, if it's ever accepted, who knows, led by our colleague Natalie Tuckey, which is about advocating for earlier palliative care for the exact same reasons that you're thinking. Like, as soon as you have like a life-threatening disease, palliative care could start the next day. We have this kind of idea that palliative care is like for your last weeks. But actually, if you have years, why not thinking about more existential ideas like purpose and, relationships and this opportunity maybe to forgive people that you've had arguments with for so many years and these kinds of ideas. So you two, between the two of you, have just given me a good opportunity to spruik myself and talk too much. But so do you think, because this is the other thing, is like it just takes time too. Like if, let's just, I don't know Barnaby, so I feel a bit funny talking about him, but let's just imagine, because he's a co-author on the paper that we're about to talk about, if he hears about well-being and goes, actually, that's a pretty cool thing. Maybe we have had the focus a bit in the wrong direction, could bring it back, like swing the pendulum slightly. It still takes like 2 years before he'd have, a funded research project, data collected, all these sorts of things, then publication. So like someone like me on the outside won't even know that it's happening until like 3 years. These things take time, right? Do you think where on that little like 3-year schedule do you think you see it in your space?
Well, I definitely hope so, and I'm bloody gonna advocate for it. as long as I will can continue my position at Origin, that would be definitely the way I would like to take my research, to focusing on like how to live good life and well despite the illness. So and then obviously like you can have the one funding to do one research, but that only gives you one cohort. Like that needs to be repetitive. And if you think about current mental health research, like well-being scales are often left out, or there is no, it's randomly selected. There is some like systematic reviews trying to think about it, but then we have like also frankly too many scales measuring sort of the same thing. And it's really frustrating in that sense as well, because like if somebody would ask like, okay, we want to incorporate the idea of mental well-being, what scale do you suggest to use? And I'm like, that's a very good question. There is 200 of them.
Yeah. And you end up sounding like a terrible advocate. Like you said, you're going to be an advocate, then they finally ask you for it, and then you say, well, I actually don't really have a very good answer. I mean, I'm sure you would have one that you would give them, which is a good one. But Anna, what were you going to say?
Just let me catch back about what you said earlier about the palliative care, because just it made me realize maybe what we are doing or how we're treating this mental health approach is that we're chronifying mental health states.
We are what? Sorry?
Chronifying, like make chronic.
Yeah. Cool.
So like rather than preserving health, we're just trying to merely maintain it. And I think this is a subtle shift, but it could mean a milestone. Because what you were talking about with palliative care, I mean, this is a very hard and I mean, I don't know, miracle what they do, but this is always after that. If we could just move these efforts a bit before, without removing them where they're placed now. I mean, this engineer, what about that? Maybe we could, it's like translating that into the preventive approach. So just to close on, there's this small thought, and about what Kiira was saying is, yeah, I mean, you pointed out about this question of funding, of time, and what doesn't show up results in the short term, like immediately, it's not of interest in terms of funding priorities. And we know that sometimes research funding follows from institution design or from system design. So well-being sometimes is hard to find. Why? Because it takes time and because of the counterfactual. We can't measure what doesn't happen. So if we prevent onset, relapse, then that's hard to capture.
Yeah.
We can't prove this work because we don't see any effect there.
Yeah.
Because we're preventing.
Yeah.
So I think that we still have to learn how to pick the right words to convince not only funding agencies, but policy statements, different approaches, just to get our hand up and say, hey, okay, we have to think in different terms. We cannot use the same rule to measure the results of these two approaches.
Yeah, no, you're spot on, and I think we've seen that come to life in different ways. Where from the cancer project that I mentioned, where the palliative care thing came from, we actually just literally a few hours ago got an email from someone who was in our pilot study and said she had what's called smoldering myeloma. He or she actually, I actually don't know. They had smoldering myeloma, which is like a precancerous stage of a terminal cancer called multiple myeloma. So this smoldering myeloma, you don't have any symptoms yet, but you're just sort of waiting, and there's all this anxiety attached with, like, one day my blood test will probably say, yes, now I have the full cancer. And anyway, she was basically saying, as a result of being in the program, it did inspire her to think of health and to learn these habits of how to be more physically active, more mindful, these sorts of things. And she's gone and lost like 30% of her body weight. I think she went from sort of obese weight range to healthy weight range. And we're all obviously celebrating. That's amazing. But a part of me in my head was like, I don't want to be that guy. But it's like, how the hell would we have proved that? How can we actually demonstrate these sorts of things? Do you know what I mean? Because that might be, we sort of like roughly, like, what would be the health benefits of that, first of all, of helping and I don't want to sound too crass, right? Because I'm just turning a human person into data now. But if we could say that these types of things in clinical populations, these types of interventions can prevent, chronic obesity for the next 40 years, like, I'm not going to be alive to do one of those studies. Do you know what I mean? And let alone the sample size that you need to demonstrate it. So I agree with you, Anna. Like, I guess I'm trying to say in a very long-winded way, we can probably fall into the habit of trying to appease the system and the sort of like the KPIs of the system. Like, we want to see less hospitalization. We want to see blah, blah, blah. But there's a risk that then we lose sight of the fact that well-being is actually a valuable thing of its own right.
Absolutely.
Yeah, absolutely.
Absolutely. what about the structural, the structure of the system? I know that maybe in Eastern cultures, the attention to these corners, like quality of life, flourishing despite illness, is embedded into the healthcare system. So you have opportunities, you have time, you have resources to invest in your resources, rather than basically provide services to cure or to provide you with the best options given your condition. So a bit connecting this with the idea that we mentioned at first about how we understand really what is health overall. I think that it has a lot to do with that too.
Yeah.
Because if that evolving turns into a strategic priority, then would be in a better position to make this more reachable to the overall population, not just the sick one.
Yeah, absolutely. And you remind me of a book that I tried to read. I think he might have been Finnish. It was too complicated for me. It was called The Phenomenology of Health or something like that.
Doesn't ring a bell. No.
It was so interesting.
It comes from the Taoism line of knowledge or not?
Don't know. Like I said, I didn't get very far in it. Friedrich Svenus. I'm not sure. I should have probably checked this before I looked it up. I'm just Googling now quickly, but he is from Sweden.
Nordic.
Sweden.
Yeah, Nordic, but not Finnish.
Friedrich, Sveneaus. Anyway, that was really cool. I think you'd be interested in that, Anna. But anyway, that was another complete distraction. So I apologize. I think I'm going just in every direction today. Kiira, we haven't heard from you for a little while. I've been talking too much again. Any thoughts so far on whatever I've been talking about?
You put me in the spot here.
Sorry.
Loving listening to you guys. No, I think it's a very, very good point that you're raising.
Can I say something?
Just of course.
To connect, not going back. I'm very destructive girl too, like going back and forth.
That is absolutely welcome. As you can see, I sent you guys questions I haven't even asked. I don't think one of them, so I apologize. What were you going to say, Anna?
And we just started a project in the university, in our faculty. And this is a faculty of education, social work, psychology students. And this is like one of the leading projects. We want to implement an intervention, a preventive psychological health-based intervention to promote well-being among university students.
Mm-hmm.
Why? Because we're seeing how this, we know, and at Origin, they work with youth. We teach to young people, because here in Spain, like the education, the academic system is that you teach and at the same time you do research, equal weight. I know that in Australia it works a bit differently. So this gave us a chance to see how undergraduates, especially freshmen, were doing in terms of psychological health troubles. So we're researching a lot. We're saying a lot about youth increased rates of psychological illness, and we're not really providing something to the future psychologists, teachers, social workers. So then it was like, okay, this is our field. This is our home. This is our responsibility to do something. So we design, but we recycle an intervention that we were running in high schools, even in high schools with vulnerable children. And we adapted that to undergraduates. And we included a transdiagnostic approach, which is something that I really nurtured from it and at Origin. So basically balancing out, doing activities, providing strategies to manage the bad things, which is these anxiety rates, depression, stress, workload, toxic relationships, and at the same time providing you with tools to nurture your protective factors. So this is a transdiagnostic prevention intervention that we just started. Like, we're now collecting the data
Cool.
because what we want to do, and this also connects to our previous discussion about timing, is that we want to measure in an ecological setting. So we're using ecological momentary assessment for 2 weeks to see if this pattern of relationships between different things of psychological health or mental health, how they change before and after the intervention. So we have, this is a complex project. This is the first time that I'm leading it. I don't know what the outcome would be, but the idea was that let's try to see if we can prove that in a different way, that well-being matters, that prevention matters. Let's gonna take these people, just follow them along 2 weeks, run the intervention. This is a 9-session program. Test again with ecologically momentary
EMA.
and to see if like more nuanced patterns differ, because maybe we're just measuring most of the time this cross-sectional design, right? Like the snapshot, which is cool, it's nice, it's informative, it's necessary. Now let's gonna delve a bit deeper and that's gonna examine if changes appear or emerge at different levels.
Yeah.
This requires adopting like a complexity view from complex systems, this is another point.
Yeah, awesome. That sounds really cool. And it would be so interesting. I think this is something that we talk about a lot, is who will benefit from what sort of thing. So if you come in with issues with distress, will you reduce distress, but maybe well-being doesn't change? Or vice versa, if you have low well-being and no distress, maybe your well-being will improve. Do you know what I mean? Like which outcome, because that idea of trying to understand which program components are effective for shifting which outcome, if not both. And EMA, I think, puts you in a perfect position to think about some of that. That's really cool.
And I can tell you that most of the findings that we have, seen is that this kind of well-being interventions reduce anxiety, depressive, and stress-based symptoms rather than promoting or enhancing this flourishing aspect, which was a bit counterintuitive at first. And then we started thinking, okay, maybe we need to measure things differently in order to capture the effect of these prevention efforts. So we think that we have to really take both things into account. How we measure it, not only in the scale self-reports or the methodological approaches, but also the timing when this is happening.
Mm-hmm. Yeah, absolutely. And it's a bit like that person that we sort of said, that person who I just said finished our pilot study. Like that's been like 6 months since we heard, in terms of timing. I think we assume, that they'll go through our program, they'll get all these benefits, because we're so smart, we've changed their life, and then they go off, and then like who knows. But really, like if we've done a good, for us, our sort of the determinants we want to shift are around knowledge, about self-empowerment, about what's the word, agency over their well-being. We should expect to see long-term outcomes, but there's such a variety in what those outcomes would look like, because the things that people for themselves want to care about or work on is so unique.
So yeah, I think the agency is one of the interesting terms and topics in this. And also if you go back to like the illness side of things, or like when we have young people who are challenging like in early psychosis, or like when I was working in the psych ward, And these were like young people with intellectual disabilities as well. So we were in the position where by biological age, they would be in 16, 18 and considered adults, but by mental age, they were like age of 3 or 5. And then you're sort of trying to like, okay, well, what is mental well-being will look this person, how we can support the agency and the autonomy whilst like giving them good quality of care. And I think that's like a really interesting, and I just actually, that different story, but I had a chat with my friend yesterday exactly about like education and like university students. And like, we were like, why they are not engaging and like, why they're not asking or like proactively do this X, Y, Z. And then it's like, well, if you don't know where your limit, like you can do that. You don't know what you can ask for type of things. And I think that's like, if you can support the agency in one way. And I think that's something that is missing in the current field in psychiatry, because we are focusing like, we are treating the symptoms, we are treating that, but not actually what the people want. Like, is this freeness the main goal for them, or is it something that we think?
Exactly.
And I've seen a couple of like papers or like studies showing that actually what the health professionals think what we should be treating is very different what the community wants. People living with illness are fundamentally people. They have the same wants and needs. And like, if you're a young person, this is again an example when I was working at psych ward, they were turning 16 and they got really sad because they realized they could never probably drive a car, or they can never have a beer. And then you sort of like, okay, yeah, like shit, this is actually like quite sad and like probably should be addressed. And it just looks, yeah, different to everyone. And then having that sort of shared decision making or like supported decision making what comes to your own care, it gives you the autonomy and the agency as well of your own well-being. And I think that's something really powerful that could be incorporated into psychiatry as well a bit better.
And I think that we're very scientifically biased, isn't it? Like we need to find the evidence that this works, when we know sometimes just by commentaries, by feedback, that they're enjoying that time. Maybe there's no a significant effect, but we're giving them the opportunity to feel good for a certain amount of time. And maybe we're just missing the effects or the implications of the accumulation of these small bites of momentary, like relief. No, we always look for that, right?
Yeah, you're right. You're exactly right. And I think Denise Quinlan said it on the show a couple of episodes ago. We've really inherited our methods from clinical psychology, but even really from like drug testing models. The idea of randomized controlled trials really doesn't make a lot of sense in a human setting compared to like highly controlled lab-based work. So you're right. I think like we need some really clever methodologists to come in and kind of help us here. And it does remind me, I'll give a shout out to a local philanthropic group here in South Australia. They're called the Faye Fuller Foundation. I don't know if they take donations, but people should donate to them if they feel super keen.
Disclaimer.
But what they're funding someone to do is to really think about what are other ways, like you're saying, Anna, like what are other ways of demonstrating that community wellbeing interventions are effective? Because at the moment, the government, they apply for funding to the government, and the government says, well, show me evidence that this works. But you're a community organization, you're sure that you've been doing good stuff, right? Because you're seeing it in the people, you're seeing changes in the people you work with, but you go, well, we don't have your idea of evidence. And that's a big gap. And that can go the wrong way too, right? Because people can be causing harm. They might be deluded about the impacts that they're having. And so coming up with one, so it's not just about believe everyone that just says they've improved well-being, but coming up with some alternate methods to sort of capture benefits, I think is really, really interesting.
Was that very famous quote, like, the absence of evidence is not evidence of absence.
Yeah,
right?
exactly.
Prove me or you're done. And I think that, and Kiira already mentioned before, like, what about the lived experienced people.
Yeah.
This is huge. Like the impact that it generates is huge for different communities with that. And this points again to another issue that we need to grasp with more caution. Like, we're so individual focused that what happens with the social context? We're talking about people, we're clustering people, psychosis, anxiety, depression, but they are embedded into social and cultural settings. We know that, we acknowledge that, sometimes most of the time in the limitation section. When would be the time that we put that in the upfront? Like, okay, we see changes. Either
That's so interesting.
Measured through EMA, measured sectionally, longitudinally in 3.3 years. Cool. What's happening around that people? I mean, that's any change in the family, in the social network, not the only thing. Can this drive a change, or can this to some extent influence these dynamics? Because we acknowledge that as a limitation, because of course we're not magicians, we cannot address every point. But I see a lack of progress in this question, really.
Yeah. And I'm definitely going to steal that, Anna. Like, I'll give you credit, of course, but this idea of like, let's shift some of these things from the limitation section to the abstract, because because there's so many abstracts, there's so many limitation sections that say exactly the same thing. We kind of just all brush it off, and we all sort of say, yeah, of course, it's a limitation. Of course it is. Yeah. But yeah, that's interesting. The guy, I think, so I'm totally butchering this now, but I think it's in that book that I mentioned, The Phenomenology of Health. He talks about, like, it might not be there, right? So someone can go and check. But somewhere I read, I'm pretty sure it's there, this kind of analogy that, like, the stethoscope was the downfall of medicine. And maybe I'm like making it a bit over exaggerated, but what he was saying is like, or whoever I said it, someone said that to be a doctor meant that you would be visiting people in their homes, right? And you would go to their homes, you would talk to the person, so like their experience actually mattered. You would obviously apply your expertise as well, so you're kind of working as a team. But also you're in their home, so you're looking around, you're seeing like, how clean is this place? What do the relationships look like? What kind of food is in the pantry? And then so like fully integrating like expertise, but lay experiences. And then the stethoscope comes along, and that's kind of like the symbol of objective measures. So it's like, your subjective experience doesn't really matter anymore. Shush, shush, shush. I don't have to listen to you. I'll just put my stethoscope on, and this will tell me everything I need to know. And so now I'm the expert. Now you actually come to me. Why would I come out to you? Because it doesn't matter. I'm too important. You come to me. I'll just listen to your body. I don't have to listen to you. And and that's where we end up where we are now. And so we kind of had it right, to some degree. Like, I'm sure they were like draining blood, those with leeches and stuff, those doctors. So they didn't have everything right. But we had some elements right, and we're kind of like, maybe we're starting to turn that around a bit.
Yeah, hopefully. I think it's like something balanced between both, like using the objective measurements, but also like listening to the person who is experiencing it, and like, what's the actually main goal? Is it being symptom free? Is it actually manage to go school, at a family? Like, what's actually the main importance in their life? I think, like, based on like some of my publications when I was looking in general population in Finland, I think I had this adult population, like a 50% had some sort of chronic illness. Like, it was like across like also somatic and mental. Like, what is health? Like, it's not that common that people don't have something.
Yeah.
You know what I mean? And then you start like, okay, what we're going to treat? What is important for them?
You're right.
In that sense.
And we say like the general population, like assuming that they're healthy.
Exactly.
And then you go to like Finland, which I'm sure must be one of the healthiest countries in the world, and you still see 50% of people with some sort of something going on.
Absolutely. And this is something I've also been thinking related to, like, when you go again, like clinical trials and you have your healthy controls, like how, like we assume they are same health. Like, you know, there's illness and there's symptoms that like the people we want to treat are, but then we always assume the healthy controls are this one person who is experiencing the life exactly the same. And it's just like a very silly thought in my head. And then because we just don't even focus on what is mental well-being and how it's actually distributed in our population.
Exactly.
It's actually, I think there's more variation in our healthy controls than it's in our clinical samples. And like one of the examples was like for my master thesis, we looked into brain imaging data, but more in the like a brain synchrony rather than the activity. So you see the activity being what, as you assume, like low on like clinical population and high on the healthy controls. But the brain synchrony and how people were managing what they were supposed to do were more variation in the healthy controls.
Really?
End up being the clinical population actually were more rigid and doing the same pattern, same like whatever they were doing during the task. Which all completely flips the coin that, you know, like our healthy controls are probably more variation than our clinical, maybe because they are sort of symptom for this certain diagnosis and illness. Maybe they are more similar than actually our healthy population.
There you go. There you go. I wouldn't have guessed that for your master's thesis. Now, I just realized it's been nearly 50 minutes. We haven't even talked about the paper we were supposed to talk about.
Oh my God.
I hope you're having fun and the listeners are enjoying this. I'm having fun, but I think I'm just rambling too much. I don't know. So you can tell me to kind of be quiet. But tell me, so the two of you are obviously sort of like situated in, you know, like a traditionally, like an important place. And I don't mean to diminish that. When it, you know, like I think sometimes we say like, oh, they don't focus on well-being, meaning that they're missing the boat. But actually, like you said, this is a well-respected institution with leaders from around the world. But you're sort of, you have this now opportunity maybe to put pen to paper and think about what other things that maybe could be beneficial in psychiatry by bringing in this well-being space. So tell me a little bit about the paper. Like I think we've probably covered off on some of the background, but just feel free.
Do you want to start, Kiira? Or
Well, I think I tried to bring some of the ideas like from the paper to the conversation as well earlier. So, but I think was the idea that as we see often when we're focusing on psychiatry, we're focusing on the symptoms and like basically completely left out the well-being side of things. And I think that we are missing out a lot of new, like innovative research questions that eventually can actually transform how we treat people, right? Because mental health is more than lack of mental illness and symptoms. And if we're only focusing on the symptom side of things, we only get halfway. So I always like wondered in these sort of situations that like, what is actually our baseline? What is our goal? What are we gonna achieve? And with, yeah, that's something. And then I really like how we incorporate like, you know, what works and what hurts, or like often we just focusing on when we're fixing the symptoms, illness, like that's done. But is the person actually living well?
Yeah.
Like what else we could do to promote their mental well-being or like help them like prevent getting back to the position they were? Like requires a change. And like you said, even like the intervention that you had, like it sounds like it was actually transformative change for how a person were thinking about their health, their taking the agency, what else we can do. And in research often times as well, like we're following getting the new grants and it's always a bit rushed. And like, you know, what the grants are supporting that time, you need to shift your focus. And sometimes I feel like often we forget like why we are really doing what we're doing. It's not, it should not be the papers. It should not be the public, like the citations. Like it's something nice to have and hits your ego nicely, but it's not the reason why I'm doing this. Like I want to actually help people to feel better. And that's sometimes a bit missing.
Yeah. Thank
I think
you.
The thing that I like the most about this paper is that by the time we had this first conversation where we met, along with Nelson, well, with Barnaby, not the surname, we started thinking about that. We set the main ideas, and 2 weeks later, it was written. So it was so clear to us
Mm-hmm.
that the idea was there. We saw it. We just needed to build the reasoning around. But the idea that we're proposing in this editorial is nothing new. It has been largely stated, and it was one of the first World Health Organization's statement was 1950 or a bit before. There's a very famous quote like, health is not the absence, or mental health is not just the absence, a complete state of blah, 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 blah. No, you know, like,
Yeah.
yeah, we know that, no? What has changed? Something has changed, of course, hopefully. But in terms of real integration into psychological practice, not just clinical practice, we're there. And so we just took this argument and we said that upfront, like, hey, it's about time we start trying to translate that into real strategies, into real actions. We're not the only ones. This is not our truth. This is something that, like, academia mostly agrees on. Now let's move together to make progress on this field.
Yeah. I loved I think one sentence of it that stuck with me was that idea that we'll call somebody, I'm paraphrasing poorly obviously, but we'll call somebody recovered if they now don't meet a certain threshold of symptoms, but they're probably still lacking in purpose, lonely, and without joy in their life. It was something like that, which I think basically sums up the whole story, right? And my experience has been that clinicians don't actually disagree. Like no one disagrees, really. And many clinicians actually are acting as if what we're saying is true, but it's the system that's remained sluggish, I think. Like, where do you think do you see the same idea that, like, no one's really disagreeing clearly? Like, you had this conversation with your colleagues at Origin, and in 4 weeks you've got a paper written. Like, there's not a lot of, do you get what I'm trying to say?
Yeah, absolutely. No, it's I feel like, and you're right, like I think that systems are a bit, yeah, as you said, sluggish. Also, I think it's also how quickly, like, we need to like, people come like with the severe challenges and then you're trying to quickly fix it and then you already move to the next one. I think it's also like rushed and there's no time to actually stop and think and have more holistic approach unless you have a big bank account and you're willing to put the time and effort.
Yeah.
The system is also, like, in Australia specifically, I feel it's like a maze. It's so like you go to GP, then you give a referral, then you need to book this one.
That blown my mind when I was there, and I knew how you. Sorry for that, for interruption, but that blown my mind. Sorry,
difficult to navigate.
Oh my God.
Yes,
it was a business.
It is a business, and like, yeah, like you have so many different options, and like when I'm seeking, like, I really struggle to go to GP. I know I should, but it's a big effort for me to go there, and then just to get a referral. Then I need to start thinking, okay, who to contact next? Like, there's so much, like, I need to make the decisions. I need to be booking things. Like, and like, maybe I would like someone to take hold, being like, hey, I see you. I'm here with you. I will help to guide through you. And instead of just me trying to follow it and figure things out.
Mm-hmm.
So
Mm-hmm.
I think that's also one of the challenges that we are unfortunately facing in this situation. Because like you said, everyone working in mental health field, we all share the same goal. The view is like, or how we like approach it is a bit different, but I think everyone wants to see the patient getting well and people flourishing. Like, that's like, no one will be arguing like, no, that's not what I want to do in this this area.
Exactly.
There seems to be like a cultural resistance, like discomfort, maybe that, I don't know, that runs even deeper, that most of us would like to acknowledge, with the idea that the healthcare system should be part of the business of making people flourish. It seems that treatment is legitimate, okay, but then well-being seems more like, or sounds like a coaching, lifestyle coaching.
Yeah.
It's not understood as part of the whole phenomenology of health at all. And I think that is part of our work too, to dismantle this distinction between these two sides. Because what we risk is, as you said, Matt, is that maybe we would find someone just, laying in the sofa, no more hallucinations, and I'm really simplifying the case, okay? So we reduced the symptoms, but then this person is completely hopeless, is completely, finds no agency, no meaning, no purpose. So it's like, like the engine stopped cracking, but the car is not moving.
Yeah.
And life is about moving.
Yeah. And it's sometimes I feel like we can sound almost ungrateful in a sense, because like you said, all of those symptom reduction, that is an achievement. Like, and I'm sure we all agree, right?
Of course.
So I don't want to come across as all you've done is stopped hallucinations. Like, that's important, but also we can keep going, and maybe we see some more opportunities.
And I think that there's a lot of good work out there in the outlet, and the clinical field has been always leading these efforts, the advancements, because of this traditional medical approach. So they're in a good position to guide us, to help us build equally. They are at origin, they were proposing staging models of treatment. Maybe this is an approach, this is a starting point. Maybe along this staging model, this process in which we're stepping each part of the process of the treatment process, there's the chance to integrate well-being practices and not just as today is the well-being session or today is the well-being. No, it's like, no, let's really accommodate it into this perspective, into part of the treatment, and not saying this dichotomy between good and bad, well-being distress. No, because there is part of good in distress and there is part of bad in well-being.
Absolutely. And did you ever come across, there was a book, oh, sorry, were you going to say something? Sorry.
I was just wondering, like what Anna said, like just, I think in the healthcare system in general, there is a maybe lack of agency in the system, that no one is taking like the well-being serious. Like, I like GPs and doctors are like, and psychiatrists, they have their job, they are focused on medicine, they're focusing on prescribing medication, etc. But there is like a place where you go when you want to like move past it, but you still want to be part of you still need like healthcare. Because it seems to be like it's only focusing on the symptom reduction, but there's no one saying like, hey, you can always come here if you want to focus on like everything else. And that could be also one of the solutions, including the staging modeling, that like the level of care and what you're going to get provided. Because in our cohort that we are studying in my team, they are like clinical high risk in psychosis. So these are young people who are severely ill, but haven't experienced psychosis yet. So it's also the question, or like even a bit earlier, like what level it makes sense to introduce medication, what level it makes sense to have like less invasive treatments options. And then we also know that there's a lot of people who are like resistant for treatments of all kinds. So I think there needs to be a bit more like creativity and how we're going to do it, and like options in that sense, how to provide the care.
Absolutely.
Yeah, I remember Aaron Jardin used to say all the time, I'm sure he still says, that we often don't start with like an ideal scenario. So like we're all like trying to just tweak little things around the edges and this kind of idea, but we never start with like what would be the absolute optimal care that we could think of for a young person with psychosis, right? And in the optimal scenario, like if we drew that picture, and I'm sure Origin would have something like it, it wouldn't stop with somebody having no more symptoms and that's it, right? There'd be some referral to the next place who can help, whether it were a coach or a counselor or, help you find a job, help you find something like this. We don't ever get this opportunity to actually just take a step back because we're so busy in our own races that we don't get this picture of what should it look like, which is kind of where I was hearing from you, Kiira. What would the best case scenario look like?
Yeah, absolutely. And then like there is like, and obviously there might be a lot of innovations, but then like actually translating that to reality, getting the
Of
funding,
course.
getting this being sustainable. Because like one of the things that I always struggle is that like we have all these ideas, but our grants are like 2 to 5 years. Then you build something and then you move on to the next one. But what happened to these massive, beautiful intervention programs, whatever we are creating? And that's something like one of the biggest challenges that I'm facing with research. Like, unless you're giving to someone else who can take care of your baby and transform it even something bigger, what's the purpose in that sense? Because like it doesn't, because everyone has great ideas. I'm sure we're doing the same ideas multiple times in different acronyms that we use to describe our projects. But like it's not really getting anywhere if we don't actually can translate it, and like there is funding and there is sustainability to do it properly. And I think it's like obviously that's beyond like just a research or like a research institute. We're talking about like bigger level of things that is out of my reach.
Don't you think, guys,
For
that
now.
sometimes they are already doing things in this direction, like they're integrating activities, support groups, promoting initiatives to promote their well-being, despite systematically embedding it
Yeah, exactly.
into the overall, like way of doing things. I mean, they're touching on these aspects, but maybe as a byproduct
Yeah.
more than
yeah.
as we're well-being people. We're always the afterthought team. We focus on the important things, and then you come later. I mean, that's my sense, and this is why preventive psychology, it's not really at his best, because we know a lot about preventive medicine, transport, nutrition. But what about preventive psychology? What about stepping away from people who make you feel failure? What about finding spaces to activities? What about identifying your values, the things that you like to do that you feel useful? This is preventive psychology. This is health. And we have to acknowledge all the structural boundaries and resistance that clinicians, both physical, mental health clinicians, are facing. I mean, they have a lot of pressure.
Yeah.
Maybe now I'm more using a European perspective rather than an Australian one. But we have to acknowledge that. I want to think, and I'm sure that they're doing their best, but the system, the structure, they don't provide the support, the time to do that. So we can spend a lot of time discussing about our dreamy framework, but then we need a lot of time, effort, and pressure, to say, hey, okay, maybe we can't start by introducing some touches on things from the wellbeing field as part of the initial staging in the first session, in talking about, okay, this disturbs you, but just tell me something about of your day that you really enjoy, or what it means. Like sometimes is more a shift in your mindset as a professional rather than having a huge training. And because I don't think it's a matter of training, I think it's more in terms of how we understand that the system can truly balance out these two forces.
Absolutely, I agree. And I think there's so many like good researchers doing fantastic stuff. There's so many grassroots association doing incredible projects. There are like amazing stuff happening all around, but there's just so like we just don't know about it, and it happens all the same time.
Yeah,
so it's like this sort of like, yeah, you need to trust the process.
trust the process.
Very cool. Very cool. All right. Well, thank you very much. This has been really awesome to have this chat. Is there anything like, because I did give you a lot of questions and I think we've roughly covered them off. I haven't sort of like technically asked any of them, but sort of anything you wanted to say that we haven't had a chance to say?
Oh my God. Let's take time. Let's embrace us. to push all this work in the place it should be. I think that we're doing a very good job. And I think that we're gonna ride the landscape that we all deserve in this field of mental health. We're gonna reach it. Yes.
Awesome. Very optimistic. I like it.
Yeah, what I like, maybe something that I find well-being extremely interesting and valid, and I think it has a position in every aspect of life. Like, I've seen the most happiest people who are living with illness and disease, like disorders, but I'm also seeing a lot of suffering and hardship in people who would not feel those diagnoses. So I think there is like an aspect to impact in every aspect in the population. And I think there's in the core understanding what well-being is in a population level or individual level, because I do think it alternates and depending what sort of resources you have. It's like very understudied to actually understand what it is as a term, what it like, how we can advocate it, and what it needs to be done in order to promote individual well-being. So I think there's a lot of work that needs to be done in that field.
Awesome. Well, lucky we have two people like yourselves, and I'll even maybe be arrogant enough to throw myself in there. People who are trying their best to change this, and like you said, Anna, will hopefully shift the landscape around us. So thank you so much for your time. This has really been great.
For
Yeah.
having us.
Thank you.
And we're hoping to see these upcoming papers on these shifts that you mentioned. Now we know why have you been so busy this last month.
Call the editors and let them know that they should. All right. Thanks heaps.
Thank you very much.
Awesome. Thank you.